This is Stephen, and in this video we will discuss how to analyze a leaky mitral valve or mitral regurgitation with echocardiography. Now there's a framework that I think can be helpful for thinking about any leaky valve that I heard, where someone described that you can think about the mechanism for the leak, as being either a problem with the frame or the door. All right, so if you have a door that leaks, either there is a problem in your door frame, or there is a problem in your, I'll draw the door as not so important, or there's a problem not with the door frame, but with the door itself, or with the door. Right? Typically the problem is one of the two. And so if we say that the problem is with the door frame, what does that mean for the mitral valve? Well, let's look in our apical four-chamber view. You've got your left atrium that empties blood into your left ventricle, and then over here you've got your right ventricle and right atrium. And you could have blood leaking because you have your left ventricle dilating, or your annulus dilating, or the left atrium, maybe in a patient with AFib, dilating. Any of these will pull your two mitral leaflets, apart and cause blood to leak straight down the middle backwards like this, to varying degrees. Okay, dilation of any of those can cause this problem. Alternatively, here's your left atrium into your left ventricle, RV, RA. If you have an akinetic wall or wall motion abnormality where that wall now comes out to here, what's going to happen to your mitral valve? So if your wall gets pulled out, your mitral valve leaflet will be what we call tethered. It'll be kind of tethered like this, and you may have leakage of blood in the direction that it was tethered, an eccentric regurgitation jet. This would be another example of a deformed frame leading to the leak. Right? It's a problem with the ventricle, not the valve itself. What about problems with the valves themselves? Well, you could have, so here again, your left atrium, left ventricle, and left atrium, left ventricle, and right atrium. You could have a perforation, a hole, in which case you'll get blood that shoots straight through the hole in the leaflet. This could be in somebody with an infection. And it just depends on where the, let's match these up a little bit better. Just depends on where the hole is. And if there's multiple holes, then you might see multiple jets of blood going through the hole. You can also have leaflet degeneration. So left atrium, LV, RV, R atrium. So instead of nice normal leaflets, so this would be if your leaflets are normal, something like this. You could have a prolapsing leaflet. What does that look like? Well, a prolapsing leaflet is kind of bowing in like this. Or, an even worse form, you could have a flail leaflet. A flail leaflet is where the tip is actually pointing backwards like this. And what you'll see is you'll notice that the regurgitant jet actually goes, it points away from the leaflet that's flail. Here we've got an anterior leaflet that's flail, and so you'll have a posteriorly directed regurgitant jet of blood. And then finally, last but not least, in terms of problems of the mitral valve that make it leak, you've got your left atrium, left ventricle, right right atrium, you can just have degeneration of the valve, calcific degeneration from old age and wear and tear, rheumatic degeneration of the valve, and that will often lead to a central regurgitant jet like that. So depending on the mechanism, whether we're talking about a problem with the frame, meaning the ventricle, the annulus, or the atrium, and those are all dilating, or the ventricular wall is just, it has a wall motion abnormality, that can lead to mitral regurgitation, or if you have problem with the leaflets themselves, a perforation, a prolapse or flail, or just degenerative leaflets, those will lead to mitral regurgitation with very specific patterns. So just looking at the color pictures, you can get a good sense often of what is causing the leak. Now let's move on and talk about how we would quantify the leak. And so for that, let me draw our apical four-chamber view here. Left atrium emptying into left ventricle, RV and RA. And we'll draw our regurgitant jet right here. You may notice what we call a zone of convergence, and then it comes down to its narrowest point somewhere around there, and then you'll see a jet of varying size. Let's shade this in. This is our color, and it would typically be blue, right? Blue away, red towards, I've drawn it green here just to contrast with the blue of our heart. So how can we quantify the leak? Well, there's one new measure that I'd like to discuss with you. If I measure the diameter right here of the narrowest point, that is called the vena contracta. Vena contracta. And that is a nice quick estimate. If we take our vena contracta and we say that's the diameter and then we say pi r squared, that is a nice quick and easy way to estimate the effective regurgitant orifice area. It's a little bit of an underestimate. Then beyond that, there's some other concepts that we have talked about before. So we can use our proximal isovelocity surface area method. We can use our continuity equations, looking at conservation of flow or mass, to look at the regurgitant fraction, the regurgitant volume, and then I mentioned vena contracta. Vena contracta just now. So how do we grade it as mild, moderate, or severe? Well, mild, moderate, severe. With PISA, the proximal isovelocity surface area, if you calculate an area of an effective regurgitant orifice area of greater than 0.4 centimeters squared, that corresponds to a severe leak. That size of 0.4 square centimeters, anything that or more is severe. Versus if it's less than 0.2, that is a mild leak. Similarly, the regurgitant volume, if we calculate our regurgitant volume to be less than 30 mils, that would be mild. If we calculate it to be 60 or more milliliters, that would be a severe leak. You can take the regurgitant fraction, that is the fraction of blood flowing, that is the fraction of blood that leaks backwards, divided by the total amount of blood that flows forward into the left ventricle. And if your regurgitant fraction is 50%, that is considered severe, right? That means if you've got 100 mils of blood flowing into the left ventricle, 50 of it flows back, right? That makes sense that that would be severe. Your heart's having to do double the work, right? And then our regurgitant fraction that would be mild would be anything less than 30. Finally, for vena contracta width, if it is less than 0.3 centimeters, that's considered mild. And if it is more than 0.7 centimeters, that is considered severe. And if you take this 0.7 value and you say that's the diameter, so divide that by 2, 0.35 pi r squared, you'll see it's just under 0.4 centimeters squared. So vena contracta is a quick way to estimate the effective regurgitant orifice area but PISA can be more of an accurate way. Now I'll mention there's a couple other things that determine that if you see, point to it being a severe leak. If you see a flail, leaflet, like we talked about right up here on the far right, you've got a flail leaflet, that usually is severe. So this right here, that would be severe. If you see that there is reversal of flow, if you see that there's systolic reversal of flow in the pulmonary veins, so we'll say systolic pulmonary venous flow reversal, that is also a sign that you have a severe leak. So flail would be one reason for severe. This would be another reason. And then also, and actually, let me just draw what that would look like. So normally, we'll do normal and then we'll do the abnormal. Normally, you'll expect to see your S wave, your D wave, and then your HO reversal. This is normal pulmonary venous flow. If instead you see that the S wave is inverted, there's flow reversal, S, D, HO reversal, that's normal. This right here, this S wave that's reversed, that is a sign of severe regurgitation. You'll notice I didn't talk too much about just looking at how big this jet here is. Why? Well, that depends on a lot of your settings that you have on your machine, what frequency of probe you're using, what you've set the Nyquist limit to, how much color gain you have, and it can be quite inaccurate if you have an eccentric jet, right? If your jet is here and it hugs against the side, it may not look like it fills up much of the left atrium, but it may actually be severe. So people like to often look at the size, the amount of the left atrium that the color jet fills, and that can give you a quick approximation, but you have to be aware that there's significant limitations. And so that's why we like to often use some of these other quantitative parameters to decide if mitral regurgitation is severe versus if it's mild.